and we will start our second day of Congress with the lecture, State of Art in MD Anderson Cancer Center, Professor Kantarjan. I would like to invite also Marina Konopleva and Professor Ravandi to moderate this session. Thanks for the patience.
Thank you. I'm going to give you an idea about what we're doing today at MD Anderson for ALL, which is drastically different from what is done in most of the centers in the United States and in Europe. So I beg a little bit for your attention, but we are in the midst of a therapeutic revolution in adult and elderly ALL, which I think will, in the next 3 to 5 years, change how we treat ALL in general. So this is the survival in pediatric ALL. The claim is a cure rate of 90%. I think it's more like 80% if you include everybody rather than patients on protocols. And this cure rate is at the expense of the fact that you have to give 3 years of intensive chemotherapy, and many of those cured children are debilitated adults physically, emotionally, socially, and financially. Doing the same intensive regimens in adult ALL has given us a cure rate of about 50%. Now there's a plateau. You cannot intensify the chemotherapy, so we have to resort to other treatment modalities such as targeted therapies and others. Now, why are we doing worse in adult ALL? It is because there are 4 subtypes which have different incidences among adults versus children, and they have different prognosis. The first 2 are the hyperdiploid and ETV6 ranks 1. They constitute close to 40% of pediatric ALL, less than 10% of the adult ALL, and they have a very favorable prognosis. The third is also a well-known entity, Philadelphia positive ALL, which is about a quarter of the adult ALL, but only 5% of childhood ALL. And this historically had a very unfavorable prognosis, although with the new treatments, I think it is now one of the most favorable subtypes of ALL. The last entity is recently described and will be detailed by Dr. Konopleva, Philadelphia-like ALL, also historically unfavorable with the old intensive chemotherapy, but not anymore in our hands with the addition of antibodies to chemotherapy. I do not like the term Philadelphia-like ALL because it implies that you can treat all of them as Philadelphia-positive ALL. In fact, only a quarter of them can be treated like Philadelphia-positive ALL. So if you take 100 patients with pre-B-ALL, 25 will have Philadelphia-like characteristics, but only 5 on the right side will be the ones that you can treat as Philadelphia-positive ALL because they have the able translocations. On the left are the majority of the Philadelphia-like ALL. These have CRLF2 overexpression with or without JAK2 mutations. There was the notion that they could respond to ruxolitinib, but I do not think that that's true. I think they respond very effectively to antibodies, and we may need the addition of venetoclax at the end, but I don't think so either. So how did we make progress in adult ALL? I'm going to summarize a lot of research in 20 years with what we're doing today. So today we use ponatinib and chemotherapy in Philadelphia-positive ALL. Dr. Sabina Chiaretti will show you later her work with dasatinib and blinatumomab, which I think is outstanding with the early results. But the question is, can you avoid the allogeneic transplantation with such an approach? Another breakthrough was the CD20 positive ALLs treated with rituximab. This has improved the cure rate by about 10 to 15%, and now we're using ofatumumab with better results. The real breakthrough is the discovery of inotuzumab and blinatumomab and adding them to chemotherapy, not only in the salvage but the frontline setting. I think the CAR T cells are an important scientific breakthrough, but they will not affect the majority of patients with newly diagnosed ALL. I think it will still be a salvage therapy. And finally, the importance of minimal residual disease. And now we emphasize MRD at CR rather than 3 months into therapy, because I think that's prognostic and predictive, and we're changing therapy if patients are MRD positive at CR. This is the current regimen, the hyper-CVAD ponatinib. So it's 8 intensive chemotherapy with ponatinib. I would like to highlight that we increased the intrathecals to 12 because we were having, as the patients were living long, about 10% who had CNS leukemia. And also the ponatinib goes down very quickly to 30 milligrams a day, and then 15 milligrams in a complete molecular response. This is the updated results. We stopped the study at 100 patients, and we replaced the hyper-CVAD with mini-hyper-CVD because we realized that this regimen is not palatable to the community practice in the United States, and they are resorting to single-agent TKIs with minimal vincristine steroids, which I think is harmful to the patients. So when you look at the estimated 5-year survival, it's about 75%. But notice the incidence of flow cytometry MRD negativity, 100% of the patients achieve that. The incidence of complete molecular response is 84%, and that avoids going to transplant in most of the patients. Today we have this program of ponatinib blinatumomab, essentially because many of the patients who relapse either on the old TKI intensive chemo, or even among the patients on Dr. Chiaretti's study with dasatinib blinatumomab, the patients are coming up with T315I clones. So this is what we are going to do in patients who are not eligible for the intensive chemotherapy. So today we have 2 regimens, the mini-hyper-CVD ponatinib, and we might add blina or ino in patients who are still PCR positive on other protocols to try to avoid the transplant in 100% of the patients. And this is our next program with ponatinib blinatumomab. Now, in 2000, we added rituximab to chemotherapy in pre-BALL to the hyper-CVAD regimen, showing positive results. This was taken by the French group, and in a randomized study, they showed that adding rituximab improves the survival significantly by about maybe 15%. So if one thinks about it, rituximab has 0 single-agent activity in ALL, yet it improves the cure rate in combination with chemotherapy by 10 to 15%. So what if we have antibodies which are not only active as single agents, but they have superior efficacy to chemotherapy? Can we then start treating ALL with much less chemotherapy with antibody cocktails and perhaps reach a cure rate that could exceed maybe 70%, which is my prediction for the future? So there has been a reversal to pediatric-inspired regimen in patients up to the age of 40. And this is an update from Dr. Wendy's talk that shows that using the pediatric-inspired regimens produces an estimated 5-year survival of about 60%. So that's the bottom line. Up to the age of 40, if you use pediatric-inspired regimen, the potential 5-year survival is 60%. When we compared our hyper-CVAD to pediatric-inspired regimens, the survivals were the same. So we went back to the hyper-CVAD because we're more familiar with it since 1992. We're starting to reduce the RAC from 3 grams to 2 grams per meter square and the methotrexate by 25% to make it easier to deliver in the community practice. But in 2012, we replaced rituximab with ofatumumab. And here I show the updated results which will be published. Again, a universal CR rate. MRD negativity 93%, so Philadelphia-like doesn't matter anymore. Historically, 80% of Philadelphia-like were MRD positive. We don't see this anymore, and the mortality remains low at 1%. And this is the survival. So the estimated 5-year survival is 60%, but remember, this study is not up to the age of 40 now. It's up to the age of 60. So we can treat patients up to the age of 60 with the hyper-CVAD ofatumumab and hope for an estimated potential cure of 60% across the board. And if you look at the patients under the age of 40, then the estimated 5-year survival is 75%. So major progress in my mind with the hyper-CVAD of ofatumumab. Can we do better? Of course we can, and this is our current regimen in people under the age of 60. Hyper-CVAD, inotuzumab, blinatumomab, only for intensive courses. The maintenance is only for 1 year. We rely mostly on inotuzumab and blinatumomab to increase the cure rate. Now, when do we do transplantation? Because that's a common question. At MD Anderson, we do transplant in a minority of the patients. So actually, the indications for transplant at our institution in ALL in first remission are shrinking rather than expanding. So we, of course, transplant all the AML, ALLs because they are not doing well even with the addition of antibodies. We also transplant patients which have the rare complex karyotype, 5 abnormalities or more, and the patients who are near hypoploid with P53 mutation. And the third indication is precursor T-cell ALL until we get more data with the addition of venetoclax to nelarabine asparaginase to hyper-CVAD in the frontline setting. The 3 bottom ones, we are not transplanting anymore consistently. Philadelphia positive ALL, if they are PCR positive, we add blina or ino. Philadelphia-like, unless they are MRD positive, we do not consider transplant. And even if they are MRD positive, we consider the transplant only after using blinatumomab and inotuzumab. Now we come to the therapeutic revolution, which comes in 2 flavors. I believe in the left side, the addition of antibodies to chemotherapy and the cocktails. Most people believe the CAR T cells is what will drive the potential cure in ALL, and I disagree with that. I think it will have a role in the salvage setting. So, as you know, both blinatumomab and inotuzumab are approved in the United States and I think in Europe as single agents for the treatment of refractory relapsed ALL. And this was based on the 2 randomized trials. On the left, blinatumomab versus chemotherapy in salvage that showed a doubling of the CR rate and a modest improvement in the survival. On the right is the inotuzumab versus intensive chemotherapy, again showing an improvement in the CR rate to 74% versus 30%, but also a modest survival benefit. Since the FDA approval in the United States, I have never used either of these antibodies as single agents. I have used them always in combination with chemotherapy because you can double your benefit. So let's see the results. We combine this with mini hyper-CVD. Mini hyper-CVD should be able to be delivered even by community oncologists or even regular internist. It does not have adriamycin. Cyclophosphamide is 50% of the dose. The methotrexate is a quarter of the dose. The Ara-C is less than 20% of the dose. We added the inotuzumab, but not at the FDA-approved dose of 1.8 milligram per meter square, because that dose can cause veno-occlusive disease. Actually, the cumulative dose that causes veno-occlusive disease is 5.4 to 7.2 milligrams per meter square. In this regimen, we use at most 2.7 milligrams per meter square. So we're way below the veno-occlusive dose. This is the regimen, 4 cycles of intensive of mini CVD with a lower dose of inotuzumab with a total cumulative of 2.7 per meter square. Then 4 cycles of blinatumomab, so that if you're using it in the salvage, you space the last inotuzumab from transplant and you reduce further the incidence of veno-occlusive disease. And we use ursodiol, and then a maintenance phase for 1 year. Let's look at the results in salvage. Now, I want you to pay close attention. In salvage 1, a patient who relapses, who was an adult, this was a death sentence. The CR rate was 40% in salvage 1, 10 to 20% in salvage 2, and the cure rate of less than 10% even with transplant. Look at salvage 1 now. A CR rate of 90%, as good as in the front line. In salvage 2, the CR rates are 50 to 60%. Many of them are MRD negative. And when you look at the outcome in salvage 1, the estimated 3-year survival is 50%. Many of them without a second transplant. Even in salvage 2, we're curing a quarter of the patients. So these results are as good as CAR T cells in this setting of active disease. We could not take this regimen to the younger patients because I showed you that the high-perceived ofatumumab in the younger patients under the age of 40 has an estimated 5-year survival of 75%. Up to the age of 60, it has an estimated survival of 60%. But in the older people over the age of 60, the high-perceived produces a 3-year survival rate of 20%. So we said, well, let's use the mini hyper-CVD inoblina in the older patients. And what you see is, again, a universal CR rate and 0 mortality because the intensive chemotherapy is low. Flow cytometry MRD negativity, 95%. The best results we've ever had in the elderly. When you compare the mini hyper-CVD to our own historical experience with hyper-CVAD, where the estimated 5-year survival was 20%, now we're up to 50%. Remember, 50% is as close as what we used to get in the 1990s and 2000 with intensive chemotherapy in people under the age of 60. So we're very happy with the results. But notice one more thing on the previous slide. Notice one more thing on this slide. When we divide them by up to the age of 70, the people 60 to 70 have now a potential 5-year survival close to 60%. The ones over 70, they have a lower survival rate. But it is not because they are relapsing. This is the age of 70. They are not relapsing, so they are dying in remission from either MDS-AML or from myelosuppression complications. So in the patients over the age of 70, we amended to 2 cycles of intensive chemotherapy, no more pump maintenance. The total INO dose is only 1.5, and we'll see whether we can reduce the mortality in CR in patients 70 years or older. What are some of the next questions? So ponatinib blinatumomab may be a potential cure in Philadelphia positive ALL without any chemotherapy. I showed you the data in the salvage and the frontline in the elderly with the new regimen. We're starting to test venetoclax in the context of chemotherapy in ALL, and we're going to look at subcutaneous blinatumomab to make it easier on the patients. Thank you for your attention.
Okay, we have time for questions.
I made up all the time for you.
We have time for questions. Any questions?
What do you think about full pediatric therapy up to 40 years, which we applied with very good results?
I think this is now the most commonly used regimen up to the age of 40. At MD Anderson, we do not like it because there are a lot of asparaginase toxicities, and we barely can apply it to the age of 40, so we went back to the hyper-CVAD combinations at our institution since 2012.
Questions, Dr.
Prof, CAR-T, in your opinion, are for salvage regimen. Which is, in your consideration, the best patient to undergo to CAR-T treatment in this subset?
If you have adults with ALL, I think the CAR-T cells would be a good salvage 2 treatment. They are not approved for salvage 1, and they are not approved for people over the age of 25. So I think for salvage 1, the mini hyper-CVD inoblina is probably the best regimen. in salvage 2 and beyond than CAR T cells, but you have to get an approval for some CAR T cells for people over the age of 25. You cannot do it at present.
Okay, thank you very much, and we're going to move to the next speaker, Dr. Papayanidis, who is going to talk about treatment of ALL, both pH positive and pH negative in Italy.
Thank you. Good morning, everybody, and thanks again for this kind invitation. So let's talk about pH negative and pH positive ALL in Italy. These are my disclosures. These are the topics of my talk. So first-line therapy and stem cell transplant indications, treatment of relapsed and refractory ALL, and treatment of pH positive ALL. So in the last 13-15 years, we have learned from our pediatrician colleagues that also in adult ALL patients, treatment intensity matters. And such a successful approach that our colleagues have developed is based mostly on the factors that you can see here in this table. In particular, the introduction of high-dose methotrexate, in particular in TALL, pegylated asparaginase, if we know that, even if we know that toxicity is a concern, treatment intensity and adherence through treatment intensity, and stem cell transplant, which has now a limited use based on MRD evaluation. Many clinical trials have compared, at least in population up to 5 years old, clinical approaches with pediatric-inspired trials and adult schedules. And what we can see in this table is a benefit from pediatric approaches in the majority of the cases. Parallel to this introduction of a therapeutic approach based on pediatric styles, also in the adult population, the concept of MRD treatment was introduced. And today, we can say that at least in 90% of the patients, we are able to identify MRD through a molecular analysis. And these are data from the last NILG 09-2000 clinical trial. And many trials that are reported in this table show that the outcome of ALL patients achieving MRD negativity is reproducibly good without allogenic stem cell transplantation, showing rates of overall survival and disease-free survival ranging from 50 to 70% at 5 years. A recent meta-analysis published 2 years ago by the American groups showed that MRD strongly predicts outcome in pediatric and adult ALL, regardless of MRD method, detection period, and ALL subgroups. So before showing you the actual currently ongoing clinical trial designed by the GMEMA cooperative study group, I just want to show the previous trial in order to understand why we decided to introduce blinatumomab, which is the major revolution in our clinical practice as first-line therapy. The previous trial was the NILG 1007 trial for patients up to 65 years old. There was, at the beginning, a risk stratification based on clinical features and cytogenetic alteration distinguished among standard risk, high risk, and very high risk. Then patients received a program of intensified chemotherapy with an MRD evaluation with a crucial time point at week 10, the so-called TP2. According to the result at TP2, patients were stratified and allocated to allogenic stem cell transplantation for patients with very high risk, independently on the result of MRD, and for standard or high risk but MRD positive patients. On the other hand, patients with standard or high risk with MRD negativity continued to maintenance therapy for 2 years. And these were the results: 55% of overall survival at 5 years with a cumulative incidence of relapse of 36% at 5 years. And these were better results if compared with our previous experiences in Italy with other trials. But the other side of the coins, 2 issues. First, MRD negative patients often relapse. You can see here 28% at 5 years relapse with a disease-free survival of 64 at 5 years. Second, if we consider patients according to treatment allocations, patients who proceeded to allogenic stem cell transplantation have an overall survival of 58% at 5 years and a disease-free survival of 48% at 5 years, so such a poor outcome. This is just to confirm that if we have an ALL which is chemo-resistant with persistent of MRD positivity, allogeneic stem cell transplantation is able to rescue only a minority of these patients. And this is one of the many experiences in this field. This is an Italian study showing that both in Ph negative and in Ph positive ALL, going to transplant with an MRD positivity translates to a high risk of relapse. So merits and limits of the MRD-driven strategies: high predictive power of week 10 MRD, but technology can improve. MRD-driven strategy failing in 25% of MRD-negative patients, and poor results with allogeneic stem cell transplant. So how can we improve these results? Blinatumomab, of course, may help us in this field, and in particular data coming from the BLAST trial, and this is the last update presented at the last CHA meeting in Amsterdam in June by Nicola Gogubuket, showed very brilliant results with an estimated 5-year overall survival for complete MRD responders patients of 50%. So starting from this rationale, the currently ongoing GMEMA LAL2317 clinical trial for patients up to 65 years old was designed at the beginning stratification with the same parameters described before. All the patients after the 3rd course of chemotherapy and after the 6th course of chemotherapy received blinatumomab, with a primary endpoint to define the capability of this drug to convert the patients MRD positive at TP2 to MRD negative at TP3. And what are the indications for transplant? No transplant for standard or high risk MRD negative, early transplant for all very high risk patients regardless of MRD results, and transplant suggested for standard or high risk patients but MRD positive at one of the time points that we go to analyze. What about elderly patients? This is a review published 6 years ago by Nicola Gogubuket, who suggests us, and it is, I think, a very important point in our clinical practice, to assess the fitness of our elderly patients before saying if a patient has or has not to proceed to a program of chemotherapy. Age is not enough to say if a patient needs or not to be treated. And in my dream, I hope that the so-called palliative approach would be cancelled forever, because now we have a lot of important tools and promising drugs in our hands, and I hope that we'll be able to offer them to the majority of our patients. However, we know that if we treat elderly patients with an intensive chemotherapy approach, it's not a good thing, and also because we are not able to maintain the dose intensity, and you all know that maintenance of dose intensity is one of the most important things that is at the basis of the success of pediatric approaches. What we can do now in Italy for elderly patients at diagnosis, we had the GMEMA clinical trial, which was close to the enrollment, a geriatric assessment adapted, so-called, in which patients were stratified according to fitness and received different courses of standard chemotherapy with low dosages, of course, and in some cases also autologous stem cell transplant if they were considered fit. Other options are reduced dosage BFM or mini CVD or just vincristine plus steroids. What we'd like to do, I put these pictures, all day I dream. It's not true that all day I dream because, of course, I have to work. Anyway, in my dreams, I think that the most interesting approach would be a combination with inotuzumab to debug the disease, plus or minus low-dose chemotherapy and blinatumomab. What about treatment of relapsed and refractory ALL? We all know the bad prognosis of this patient population, and we know that now we have important tools in our hands, in particular monoclonal antibodies and inotuzumab ozogamicin, which is conjugated with calicamycin, anti-CD22. You all know the mechanism of action of the drug. What is the situation in Italy? Inotuzumab is approved as a single agent for treatment of relapsed or refractory Ph negative BLL CD22 positive adult patients, or Ph positive relapsed or refractory BLL patients who have failed at least one TKI. What are our expectations based on the results of the Innovate trial? In Bologna, we had the opportunity to enroll a lot of patients in this trial, and we had also treated many patients in the so-called personalized program, in total more than 40 patients in our hands. It's not a big number for MD Anderson, but in Italy, it's a quite big experience. Our expectation, 80% of CR, 78% of the patients obtain an MRD negativity, which was evaluated by flow in this trial, and 40% of the patients were able to proceed to an allogeneic stem cell transplantation. With these results that Professor Kantarjian has already showing the best benefit in terms of long-term overall survival, 3-year, 20% versus 6.5% with chemotherapy. If we have to decide which is the best patient suitable for inotuzumab therapy, because we have also another antibody with more or less the same indication, this is my personal opinion, and I think it's good also to share during the discussion later. Of course, we have to confirm CD22 expression. Patients need to be relapsed or refractory according to the indication we have today. The drug is very active also in extramedullary leukemia. We have the problem of MLL rearranged leukemia. T411 is an issue, of course. The problem of VOD. At the beginning, we were very afraid of this topic. Now we know how we can manage it. We know what we have to do. We have guidelines, and so we have to proceed in the best way without waiting for anything. So we all know that if a patient has to proceed to an allogeneic stem cell transplantation, the suggestion is to proceed with no more than 2 courses of inotuzumab, and the other important thing is to avoid the double alkylator agents during the conditioning regimen. In Italy, we are also going to start with another trial with inotuzumab in the context of MRD positivity, and I hope that also interesting data will come from these patients. The other one, drug, blinatumab, in Italy is approved again as monotherapy for treatment of adult BLL patients, relapsed or refractory, CD19 positive, Philadelphia negative. And we have already seen before the positive results coming from the Tower trial with benefits in terms of overall survival if compared to standard chemotherapy. We can use blinatumab at every salvage line. However, we all know that the sooner we use it, the better it is in terms of outcome. You can see here the different curves in salvage 1 or salvage 2 and for the salvages. What about blinatumab in clinical practice? In extramedullary leukemia is not so active. In T411 as well. The problem of neurological comorbidities at the beginning, again, the same topic for liver in inotuzumab. We were very afraid of these potential adverse events, but if we look at data, coming from the Tower experience, you can see that in the standard of care arm, we observed a higher incidence of adverse events, including also neurological adverse events. Only cytokine release syndrome, of course, was higher in the group of blinatumab patients. So in my dream, in relapsed refractory patients, at the beginning to debug disease and blina sequentially, plus or minus low-dose chemotherapy, also based on the excellent results you are showing from your experience in Houston. Few words on TLR, relapsed and refractory patients. In Italy, we use nelarabine, and this is our experience presented at the last EHA meeting by Anna Candoni. More or less 100 patients, and the role of nelarabine as bridge to transplant in order to rescue some patients relapsed or refractory to standard chemotherapy. Next options, we don't have a GMEMA clinical trial ongoing for this kind of patients, but of course, a venetoclax-based trial would be very, very interesting, and it would be nice to have one of these opportunities for our patients. Last but not least, pH-positive ALL. You all know that GMEMA strategy from the beginning was based on a chemo-free approach using TKIs with steroids, starting from imatinib and then dasatinib. Then we had the rotational study nilotinib plus imatinib. And last but not least, the trial with ponatinib for elderly patients newly diagnosed or young but unfit for standard chemotherapy, and the trial with dasatinib and blina. Now that's in induction. I think it's the most important point because CR rate, of course, is very high, but we all know in the clinical practice that the majority of ALL respond. The problem is not the response, but the onset of relapse. What did we learn from our experience with TKIs? I think that it's important to say that MRD must be considered the final goal not only in pH-negative ALL, but also in pH-positive ALL. These are data from the study with dasatinib from line 1509. You can see here the two curves comparing patients who obtain a complete molecular response at day 85 versus patients who don't obtain this kind of response. So it's very important to obtain very quickly a deep molecular response. What we know with dasatinib is that unfortunately mutations occur very frequently and very soon, and these are data from Simona Soverini showing that T315I resistant clones are recognized between 3 and 5 months after frontline treatment with this TKI. And starting from this rationale, GMEMA decided to design the trial with ponatinib frontline in elderly patients or unfit for standard chemotherapy. Data were presented by Giovanni Martinelli 2 years ago at ASH meeting. The schedule of the trial was a pretreatment with steroids and then ponatinib at the beginning 45 milligrams daily for 8 courses of therapy, and at the end an extension phase for patients in response until progression or toxicity. This was the overall survival curve he presented at ASH with an overall survival at 1 year of 89.2%, and we hope to be able to finish the paper and submit it very, very soon. This is the ALBA trial, and Sabina will show the excellent results, the combination with dasatinib and steroids. Both these two trials are closed, the enrollment, and from a practical point of view, in Italy now, the only one TKI approved for newly diagnosed pH-positive ALL is imatinib, alone or in combination with chemo. Dasatinib is approved for pH-positive ALL and blast crisis or CML resistant or intolerant to a previous therapy. Ponatinib is approved for pH-positive ALL resistant to dasatinib or intolerant to dasatinib or with T315I mutants. In our clinical practice today, at the end of September, we have this kind of choices. On one hand, there are many sites who can enroll patients in this trial. Bologna as well is involved, the so-called Falcon trial, comparing and randomizing patients between ponatinib plus low-dose chemotherapy and imatinib plus low-dose chemotherapy. On the other hand, I think that the other centers who are not involved in this trial are still using imatinib or dasatinib plus or minus the low dose of chemotherapy according also to individual thoughts on this field. So in conclusion, treatment strategies for adult ALL patients in Italy are MRD-driven. In first CR, allogeneic stem cell transplant should be reserved to patients failing to achieve a molecular remission after frontline therapy. The results with allogeneic stem cell transplant performed with high levels of molecular detectable MRD are poor, and we hope that blinatumomab before transplant in the currently ongoing GMEMA trial would be able to improve the quality of remission and lead to a better transplant outcome. What about stem cell transplant pH-positive ALL patients? It's debated. I think that in Italy there are a lot of colleagues who really think that all patients need still to be transplanted in CR. However, I think that the point that may help us in order to give an answer to this question is to identify from the beginning other concomitant molecular alteration in order to select patients who are at highest risk of a bad prognosis of relapse. And Sabina is working a lot on this topic. The role of CAR T cells have been approved by IFA, Taizagen-Lecheuchel compound, for young patients up to 25 years old. We don't have experience yet. I personally think that we have in our hands a lot of compounds, in particular monoclonal antibodies and antibodies conjugated with, for example, galicamycin. And if we learn and use them in the better way, in the best way, maybe CAR T are not necessary. And I want to thank all my colleagues from Bologna Institution, Giovanni Martinelli, you all for your attention, and I'll be happy to take questions.
Thank you. And in the interest of time, one quick question, please. If there isn't any, we're going to move on to the next speaker. Okay, no questions. Thank you very much. And Dr. Konopleva is going to talk about biology of acute lymphoblastic leukemia.
Good morning. It's a pleasure to be here. So I was asked to update the biology of ALL this morning, in particular focusing on PH-like ALL and ETP ALL, which are considered to be poor risk subtypes. Some disclosures. So I would like to start with this slide, which was kindly provided to me by Charles Mulligan, who also supported this talk with several other slides. And this is a new classification of B-ALL based on the genomic signatures. So as you all probably aware of, the work of St. Jude and Charles Mulligan really revolutionized our understanding of the biology of the B-ALL based on the whole genome sequencing and RNA signatures, transcriptome signatures. And we've been collaborating with Charles over the years, not only by providing samples, but also testing some of the key hypotheses that came out from this research. And as you can see here, now the B-ALL can be categorized based on multiple different signatures, and all of the subsets are very clearly defined and have distinct genomics, distinct biology, and very different outcomes in the clinical trials. So I will talk today about the subset of PH-like ALL, which, as you can see, is overlapping in the gene signatures with the PH-positive ALL, which really triggered its title. And this is a sort of updated slide. Dr. Contagion already showed you that the incidence of different subsets of ALL depends on age. And as you all know, the incidence of poor risk ALL is increasing with age, with low hypodiploid, MLL rearranged, and pH-positive pH-like ALL highly representative in all the patients, which really translates in inferior outcomes before the era of the monoclonal antibodies. On the other hand, some of what we know now as positive or better risk subtypes such as hyperdiploid ALL is rare in adult, and also this new subsets such as PAX5 altered or PAX5 mutated ALL, they're also not as common in adult. And again, this is from the same paper that came out in Nature Genetics this year, which showed, based on the large, almost 2,000 sample data set from pediatric and adult cohorts, that the outcomes of ALL are very distinct depending on their genomics. And again, there's some of these newer subsets, such as PAX5 rearranged and PAX5 altered ALL, they're actually different in the pediatric and adult ALL. I think that's something that requires further studies. But here on the bottom, for both of the subsets, you see that pH-like ALL continue to be worse. Again, this is before we had monoclonal antibodies. pH-positive before the TKIs had worse outcomes. BCL2-MYC rearranged ALL and hypodiploid ALL remain an issue. So going to the pH-like ALL, it was defined back in 2009 by work from European colleagues based on the gene expression. So the data stay true, as I just showed you in the updated RNA-seq analysis. It's very similar. So the genomics or gene signature of the pH-like ALL is similar to the pH-positive ALL. The other distinctions, of course, there is no PH chromosome, and there are no major known translocations. So you can kind of exclude PH-like ALL if your patient has some of the other known translocations. In all subsets in the past, they were known to have poor outcomes, and they frequently have alterations of the transcription factor called Icarus-1. The incidence is increasing with age, with about 10% in pediatric ALL, and is most commonly in the age between 40 and 59, and also in the adult ALL, where pH-positive ALL is also very common. So simplistically, pH-like ALL, of course, it's driven by the kinase signature, but it can be genomically very distinct and different. There are many different subsets. So by sort of very poor or simple classifications, you can classify them as CRLF2 overexpressing ALL, which can be detected by flow cytometry or FISH analysis or RNA-seq if you have access to it. And about 50% of CRLF2 positive ALLs have JAK2 or JAK1 not as common mutations. And then there's another subset which is much more complex, which is driven by the rearrangements and fusions in different kinases, which I will show you in the next slide. The incidence is about 50%, but in adult, we actually see much more common CRLF2 positive ALL than the other subsets, at least in our population, where we have a large Hispanic population in Houston area. So again, going to the first subset, which is CRLF2 positive or rearranged ALL. CRLF2 stands for the cytokine receptor-like factor, and the rearrangements can be molecularly caused by translocation to the immunoglobulin heavy chain gene or deletion proximal to the CRLF2. So that these two fusions, each of them have specific FISH probe, which is commercially available. In adult, the IgH CRLF2 is predominant. And as I mentioned, they result in the overexpression of CRLF2, which can be easily detected by flow cytometry. So this is an easily diagnosed subset of PH-like ALL. They commonly have JAK2 mutation, but at a different site than the V617F mutation in MPN. There are multiple mutations. This is the one most common, but they're all transforming events. And in theory, they should be sensitive to the JAK2 inhibitors, but I will discuss that in a minute. So this is the other subset of PH-like ALL. Again, it's driven by the kinase fusions, and it's very complex. You can see that there are ABL class, JAK2 class rearranged fusions, and others, IgH and EPO receptor. And I think this work from Catherine Roberts and Charles Mulligan sort of defined the subsets in more granular detail. This was published in New England Journal of Medicine a few years ago. And again, there's ABL class fusions, which includes ABL1, ABL2, CSF1R, and PDGFR beta. So all of these are sensitive to the TKI, such as dasatinib or ponatinib. Then there's the large cohort of JAK2 rearranged. So again, in the CRLF2, you have JAK2 mutation, but this is JAK2 fusions. And there's also a small subset of EPO receptor rearranged, which have actually quite poor outcomes. And in theory, they're also JAK2-driven, JAK-STAT-driven subset. I already talked a lot about CRLF2 rearranged. They have JAK2 mutation. And then there are other lesions that also drive JAK-STAT pathway. So you can see that this pathway is really prevalent in the PH-like ALL. And they include a different subsets. I don't have time to go through that. And then there's a RAS-only subsets of ALL and some additional subsets as well. So in our center, we have looked at the retrospective analysis of 148 patients. We collaborated with St. Jude on this project. We defined PH-like ALL based on the RNA sequencing and genome analysis. So in our center, we found that 33% of patients had PH-like ALL. And before this analysis, we did not know that this is so common, so prevalent in our practice. PH positive is just as common, 31%. And as I mentioned before, in our study, CRLF2 positive patients were predominant at 60% of the population. So what is characteristic for these patients? This was already mentioned, that they are very commonly remain MRD positive, at least with the hyper-CVAD-based regimen, even with rituximab, 70% in our analysis compared to B others, which only had 13% of MRD positivity. So this is one way you can suspect that the patient might have PH-like ALL. They remain MRD positive after induction. And they're commonly Hispanic in the origin, again, at least in our center. And we now know that this is because they have polymorphism at GATA2 region that controls CRLF2 expression. And these are the outcomes data from our center. So what we found that actually the worst subset from these PH-like ALLs is CRLF2 rearranged ALL. So this is the bottom curve. You can see the survival, event-free survival. So this patient, the survival is less than 20% at 5 years. And especially if they have JAK2 mutations, the survival was very poor. Again, this was before the introduction of the monoclonal antibodies. So if you think that this is a kinase-driven subset, of course, there was a content to use the TKI similar to the pH-positive ALL. In the next set of slides, I will show you what has been done preclinically and clinically in this area. And again, you can envision targeting of different kinases depending on the genomics, so you have to know underlying genomics. So for the JAK2 mutated, including CRLF2, EPO receptor, and JAK2 rearranged, in theory, JAK2 inhibitors could be used. For ABL rearranged, including all these fusions, you can use ABL inhibitors, and then there's this other signaling class of kinases. So I think use of ABL kinase inhibitors was fairly well established. It was proven in the preclinical studies, again, from Charles Mulligan group. And you can see here that they are very sensitive to the dasatinib in this case in low nanomolar concentration, similar to pH-positive ALL. And this is, again, different fusions, but they all respond to dasatinib, and actually the response are better when combined with the steroids. There were also some of the anecdotes in the clinical practice when refractory children or other patients responded to TKI if they had the ABL type fusions. What about other subsets? So this is JAK-STAT-driven subsets, and here the preclinical data suggests that the responses depend on the genomics. In the JAK fusion ALL, they were fairly sensitive to the ruxolitinib JAK2 inhibitor, which is here the green line. But again, it's not as dramatic. But if you combine it with dexamethasone, the responses seem to be better. In the CRLF2 rearranged, again, the ruxolitinib alone can only extend survival by few days, I would say. If you combine it with PI3 kinase, there were somewhat better results. And then there's some data that adding venetoclax BCL2 inhibitor would improve the responses of ruxolitinib. So again, even from this preclinical data, there was a questionable use of ruxolitinib in this pH-like ALL subset. And finally, this is other kinase-driven pH-like ALL. In this case, is NTRK kinase fusion. And recent work published in Blood by Catherine Roberts showed that they are very sensitive to the NTRK inhibitors. These are from 2 different companies, in vitro, in vivo, and this is something that is rare but can be used in clinical practice. So based on all this preclinical work, there are several trials that are ongoing in that space trying to use the kinase inhibitors. So there are trials from both Koch and St. Jude that incorporate dasatinib or ruxolitinib in a different fashion. So usually the dasatinib is always introduced by day 15 if patient has ABL type fusion, at least in St. Jude trial, and the ruxolitinib is used for the MRD positive disease in St. Jude trial and in this CHOP UCSF trial. We had a trial with ruxolitinib in the relapse refractory setting, and we have seen very little activity, so we're not pursuing this any longer. And there was a plan to do a similar study in the University of Chicago, adding higher dose of ruxolitinib than what we used in our study. So what do we do at MD Anderson? How we diagnose pH-like ALL, and what do we do clinically? So again, as I mentioned, the first test that we do is a flow cytometry as a part of the routine panel. You can see that CRLF2, if it's positive, we can confirm by FISH, and then we do the 81 gene panel to diagnose if they have a mutation. The other subsets are more difficult to diagnose. We have been sending it out to the Child's Lab to diagnose different fusions by multiplex PCR, but we developed in-house the Archer translocation panel, which will become live very soon and will detect all of these translocations. So what do we do as far as therapy? As I mentioned, we sort of gave up the ruxolitinib. We do add TKI if the patient has ABL type of rearrangement. But for the other CRLF2 subsets, we use our frontline regimen that was shown by Dr. Kantarjian with inotuzumab and blinatumomab. We introduce blinatumomab usually after cycle 2, especially in patients who remain MRD positive, and then consider the stem cell transplant. But again, we are not sure how much transplant adds if they are MRD negative. And this is a trial that we have had, but we are not really accruing to this trial. So a few conclusions on pH-like ALL. It's fairly common, and there could be JAK2 and CRLF2 rearrangements. Again, we think that blinatumomab and inotuzumab work agnostic to pH-like ALL subsets, and we are looking at the role of stem cell transplant, but we feel that antibodies might actually do better, and this is the current approach that I already mentioned to you previously. So very briefly, I'm out of time, but I'll talk to you very briefly on the ETP ALL. So this is a cell of origin very early in the thymic precursor ETP ALL. And while WHO classification classifies them as pro-T and pre-T, the definitions of ETP-ALL is slightly different. It's shown here. It's CD1A negative, CD8 negative, low CD5, and most importantly, presence of 1 or 2 myeloid markers and stem cell myeloid markers. So the outcomes historically have been poor. This is the first paper that showed the ETP-like ALL. But in the recent analysis for pediatric trial, this is not divided by ETP-ALL, but the outcomes of TLL overall are quite positive. And the regimen that is being used has a high-dose methotrexate and asparaginase, and I'll get back to that later with respect to our experience. So again, we looked at the ETP-ALL retrospectively. We found 17% were ETP-like ETP-ALL, and the response rate was slightly higher, but most importantly, the outcomes were significantly worse for the ETP-ALL. When we looked at WHO classification, only those who fit ETP criteria did poorly. The other pro-T or pre-T subsets actually did just as fine as other T-ALL. So what did we do to improve the outcomes? We introduced nelarabine as here in the green bars as cycle 5, 7, and also during maintenance, hoping to improve the outcomes of this subset of ALL. But our recent analysis showed that actually we didn't really make a difference with this introduction. Therefore, now we have amended the trial to add back asparaginase because this is the mainstay for the pediatric regimen that we didn't have in HyperCVAD. And we're also adding venetoclax for 1 cycle in this nelarabine cycles. So then there are some myeloid mutations you could possibly target, such as FLIX3, IDH, and others. But this is all experimental. And again, there's preclinical data that ETP-ALL is driven by BCL2 dependence. And therefore, in our institution, we have run this clinical trial. It was not really ETP, but it was for elderly, newly diagnosed ALL, where we combined mini-CVD with venetoclax. And we have had very high success rate with most patients responding. This will be reported at ASH. And we had 2 ETP-ALL, which also achieved MRD negative remissions with that. There's also another study run by AbbVie where they're using combination of venetoclax and navitoclax, BCL-XL inhibitor, in the relapsed refractory ALL with a response rate of about 50% and 56% MRD negative rates. So again, what we do for ETP-ALL, we feel that we need to intensify therapy with nelarabine, asparaginase, and venetoclax, which we're doing right now. In the salvage, we're considering myeloid regimen, given the genotypes of this ALL. You could possibly target some of these mutations, and this is the indication for the transplant in the first remission. So this is the end of my talk, and I don't know if the chairman will give me time for questions. Okay, so any questions? One question, because I'm over time. Okay, if there are no questions, I would like to introduce my co-chair, Dr. Farhad Ravandi, who will update us on the MRD and ALL.
Thank you, and again, I want to thank the organizers for having us here. This has been a very exciting meeting, and I've thoroughly enjoyed it. I'm sure everybody else as well. So I'm going to give a very brief overview of MRD, and I think my time said 30 minutes, but I'm going to condense it to 15 minutes or 14 minutes. Why do we care about MRD in hematological malignancies? Because we are getting a lot more morphological complete remissions, and obviously when you have high complete remission rates, you really need to try to distinguish who is going to continue to stay in complete remission. This has been led in ALL because historically we've had a lot of complete responses in ALL, but historically we also have had patients who relapsed despite achieving complete remission. What are the assays that we can use to measure minimal or measurable residual disease in ALL? And as you know, the 2 main assays are based on flow cytometry as well as molecular analysis. Historically, molecular analysis has been with real-time quantitative PCR, but more recently, high-throughput sequencing with NGS is becoming available. As you can see from this slide, there are benefits and limitations to these assays. For example, flow is much faster. However, it does require fresh samples, and the person who reads the flow it has to be experienced in it. Whereas PCR is at least a bit more sensitive, but it is more time-consuming and more expensive. Flow cytometry has been established for quite a while now. This is a PATHEMA study in younger patients with AML with high-risk ALL, and they did show that achieving a flow negativity early after induction and as well as consolidation actually can predict for excellent outcome that was even superior to patients who had underwent allogeneic stem cell transplant. And we've looked at our own data at MD Anderson using flow cytometry over the years in B-cell ALL, and in this publication, again, we also showed that achieving flow negativity at various time points during the course of therapy is associated with better relapse-free and overall survival. So it is an important assay that we continue to use to manage the patients at MD Anderson. Using quantitative PCR, this is an original study from Monica Bergerman. Initially in the GMAL 99 study, she started looking at PCR for immunoglobulin chain rearrangements as various time points during the course of therapy, and clearly showed that on the left of the slide, if you achieve MRD negativity early in the course of therapy, you can actually have an excellent outcome. These are a few patients, about 10% of the patients, but you can see over 90% were alive and in relapse-free 3 or 4 years and 5 years down the line. Whereas if you had persistent MRD positivity, you can see on the right, you have a very poor outcome. Only about 10% of patients are doing well without relapse down the line. So then they incorporated this into their treatment decision-making strategy, and patients who were MRD failure were offered allogeneic stem cell transplant, and also the patients who were negative and then became positive by PCR for immunoglobulin chain rearrangements were also offered stem cell transplant. On the right, you can see that overall the patients who were MRD negative had a significantly better overall survival and a much better possibility of continuous complete remission. What about the role of transplant? Until recently, this was the only strategy that was available to try to eradicate MRD, and in this study, at least in the German study, they did show that patients who were MRD failure or MRD positive did better in terms of continuous complete remission and disease-free survival if they underwent an allogeneic stem cell transplant. Overall survival wasn't statistically significant. And then they did a landmark analysis, and still the proceeding with transplant was beneficial in that study. You have also been looking at PCR-based MRD, again looking at immunoglobulin or T-cell receptor gene rearrangements as well as the common transcripts. And I'm not going to go through this because I'm sure many of you can tell me about this better than I do. And, but you also agree that in this study, the achievement of MRD negativity on the left was clearly associated with much better disease-free survival. On the right, you can see that MRD negative patients actually became independent of their traditional risk categories. So the very high risk, and standard at risk essentially had similar disease-free survival. Patients who were MRD positive either underwent allogeneic stem cell transplant or had intensification of chemotherapy, and you can see any form of intensification was beneficial, and if you achieve MRD negativity after the transplant or intensification, you did better than if you did not. What about role of MRD prior to transplant? And this is a pediatric study using NGS MRD. It shows clearly that if you are MRD negative prior to transplant, you have a much lower possibility of relapse and a better survival. And in fact, there have been a number of studies that have looked at MRD prior to allogeneic transplant. So if patients are MRD negative, you can see they do significantly better in the majority of the studies than if they are MRD positive and then go into transplant. So essentially, it's important to try to make the patient MRD negative before proceeding to transplant. And post-transplant also, MRD is important. If you're positive after transplant, both by flow at the top and by NGS at the bottom, you can see there's a much higher likelihood of relapse if you're positive at various time points post-stem cell transplant. So can we actually say that these two assays are equivalent? I think if you have a very good flow assay, This is a Euroflow MRD assay, which is an 8-color flow. You can see there's a pretty good concordance between Euroflow MRD as well as the CAR-qPCR for immunoglobulin chain rearrangements. And again, here is comparing NGS with RQ-PCR. On the left is an adult study, and on the right is a children's study. And again, you can see a pretty good concordance between RQ-PCR and NGS assay for MRD. However, and here you can see that if you are negative by flow, there's still patients that you can pick up by NGS PCR. So obviously NGS PCR can be a more sensitive assay, and perhaps it can give you, identify a few patients that you actually think are negative by flow, but are positive by NGS PCR. This is a study that looked at a small number of patients and assessed them by RQ-PCR as well as NGS. And you can see in both curves, the negative patients do better than the positive, clearly. But on the right, you can see there is more separation, and this goes to the sensitivity of the assay. The more sensitive the assay is, you can be more confident about your negative result. MRD is a quantitative assay, both by flow and by PCR. If you are completely negative, there have been a number of studies that have shown that you do better than if you are positive at low levels. So I think the goal would be eventually to have a completely negative MRD to base our decision making on. And here with NGS, again, you can see if you are NGS negative, you do better than flow negative on the left of the slide in terms of possibility of relapse, and on the right in terms of survival. So essentially, MRD is an assay that can detect leukemia, and the more sensitive your assay is and it's negative, the more confident you are about the fact that the patient is cured. What about how to choose what assay? And clearly this depends on your local expertise, and also in terms of availability of resources and the costs of the assays. And clearly at the moment, all of the assays are considered useful in terms of therapeutic strategy. Briefly go over a specific case of Philadelphia positive ALL. This is the first study that we did at MD Anderson, showing that achieving a major molecular response at various time points. This is major molecular response for PCR, for BCR-ABL. This was associated with better outcomes at various time points, and more recently using a larger cohort of patients. None of these patients underwent allogeneic stem cell transplant in first remission. We did show that the achievement of complete molecular response at 3 months was the best predictor of outcome in terms of long-term relapse-free and overall survival. Clearly highly statistically significant if you achieved a CMR at 3 months as compared to lesser levels of response, including MMR or no MMR. And other groups have also shown PCR for BCR-ABL can be a very useful way of determining your effectiveness of your therapy. This is a Korean study using nilotinib, and they did show that various levels of log reduction, the deeper the log reduction of BCR-ABL was, the better was the outcome of the patients. And as you've seen this slide in one of our previous talks, there has been a meta-analysis of MRD in ALL, both pediatric and adult, that has clearly shown that there is a benefit for achieving MRD negativity, no matter what assay you use. And clearly this is what has led to the approval of blinatumomab for MRD eradication in ALL. This started with Max Tubb when he used blina in a small number of patients with ALL who were in complete morphological remission but remained MRD positive, and then using blina, he was able to achieve a MRD conversion in about 80% of the patients, and these were very durable MRD responses in patients who did or did not undergo allogeneic stem cell transplant. This is a follow-up of the same study, and again, you can see this is very durable relapse-free survival, not only in the patients who underwent allogeneic stem cell transplant, but also on the far right, patients who did not go on to have an allogeneic stem cell transplant. So clearly, conversion of MRD positivity to negativity by blinatumomab can be a very effective and potentially curative option. I'm sure you're all familiar with this large multi-center phase 2 study that used blinatumomab for eradicating MRD, and this was MRD at the level of 10 to the minus 3 or higher, and patients would receive blinatumomab at a slightly different dose than the standard approved dose. That's 15 micrograms per meter squared per day for 28 days, followed by 2 weeks off. The primary endpoint of the study was MRD conversion rate, and the patients could go on to have more cycles of blinatumomab after the initial cycle. About 80% of patients, again, achieved MRD conversion. They were MRD positive and became MRD negative, and this was independent of their preclinical and clinical characteristics. This is the overall survival, and this is clearly better in the patients who became negative in the blue line as compared to the patients who remained positive. And this is the relapse-free survival, again, clearly better for the patients who achieved MRD negativity. Duration of complete remission better. And here you can see that if you censor the data for transplant, this really didn't matter. So again, it brings the question, is blinatumomab going to be very effective in curing these patients even without transplant? It's important to note that in this study, not only they allowed patients in first complete remission, but also patients in second and subsequent remissions. I think this is a very important slide. On the left, these were patients who were in complete remission in first remission, and then they received blinatumomab for persistent MRD. And you can see here that at least there is no statistically difference if they did or did not undergo allogeneic stem cell transplant. However, on the right are the patients who are in second or subsequent remissions, and as you can see there, patients did better after becoming MRD negative and proceeding to allogeneic stem cell transplant. So perhaps, at least for now, if you're in second or subsequent complete remission, you're MRD positive and you get blinatumomab, you should still consider going to transplant, whereas if you're in first remission, it's still not quite completely clear. So I'm completely running out of time, and this is my final slide, essentially saying that MRD is important and here to stay. I know you know that in even other hematological malignancies such as leukemia, AML, as well as CLL, as well as myeloma, MRD is becoming more and more important. I think that's the function of the fact that we now have better therapeutic strategies that produces higher morphological responses. Thank you very much.
Thank you, Dr. Ravandi. It's open for questions. We have time for questions. Dr. Martinelli.
Excellent presentation. Do you believe that the new NGS assay that are more sensitive, if applied, will change something regarding the two drugs, inotuzumab and blinatumomab MRD definition and negativity?
Yes, I mean, as I showed you, if the more sensitive your test is and it's negative for MRD, the more confident you are in terms of telling the patient, I think you're cured and you don't need any further therapy. So I think if you're getting an NGS that is negative, I'm probably a lot more confident on avoiding allogeneic stem cell transplant, even in second remission or third remission. The question is how many patients will achieve that level of MRD negativity with NGS, but the fact that it's a much more sensitive test makes you more confident to say that you have cured the patient.
Maintenance therapy with blinatumomab, because there was two programs, one with maintenance, another one without maintenance. What's your opinion? What's your impression?
I think blinatumomab is a very effective agent, as we all know, and in our regimens we do give blinatumomab as our part of our maintenance strategy, both in Philadelphia positive and Philadelphia negative. So I think it is a very important drug to be incorporated in maintenance therapy. And perhaps at some point in the future, it will reduce the amount of maintenance. We have already shrunk our maintenance therapy because we are incorporating implanetumomab.
Thanks.
Very much. If there are no further questions, I would like to invite Dr. Pagano to update us on infections and acute leukemias.
Thank you. Good morning. Thank you to the organization, to Claudio and Giovanni, that said me before I arrive here, please, quick and run. Okay, I will try. But to speak regarding acute leukemia, infection in acute leukemia in 12 minutes is really difficult. So I will focus my attention and your attention on some point above all. You know that there is a lot of factors that could influence the onset of infection in hematological malignancy, mainly in AML. Are environmental, are innate immune system, are lifestyle. But yesterday, as today, the most important remains always the prolonged and deep neutropenia post-chemotherapy. The question is another. At present, with the new drugs and the new procedure that we performed in acute leukemia, myeloid and lymphoid, the risk is always the same, is increased, is reduced. Of course, there is no reduction of the risk that remain the same, but the problem is another, is the drug-drug interaction with the antimicrobial agents that we have at our disposition. So we must focus our attention on this point mainly. But before analyzing each of these agents, we can start from the arsenic acid that we use in frontline treatment for acute promyelocytic leukemia combined with ATRA. Some years ago, Japanese colleagues presented this study, really interesting. They observed an high incidence of patients with promyelocytic leukemia treated with arsenic acid that developed a viral infection, mainly herpes virus infection. Is a coincidence? Is only a causality? No, because a large studies performed in the United States in subjects exposed to arsenic demonstrated that this kind of drugs, these agents can induce a block of monocyte and macrophage and above all can inactivate and modify the proliferation of T cells. So this is a very important factor. So at present, we must consider that in acute promyelocytic leukemia, we do not perform an antifungal or antibiotic prophylaxis, but probably is necessary to administer to these patients antiviral prophylaxis. Moving on, FLT3 inhibitors. At present are the most important role of this kind of drugs, midostaurin, sorafenib, and more. And all the studies that analyze the incidence of fungal on infection, fungal and bacterial, and this in these patients, demonstrated that the addition of midostaurin to 3+7 increase the risk of infection. It's a very important point, and we come back to this point also after when we speak about the prophylaxis. Regarding the Mylotarg, the monoclonal antibodies that we used in the past, and now we return to use associated to 3+7 on the basis of the French studies. The European Confederation of Immunocompromised Host Society said us that on the basis of the data of literature that probably there is no risk for these patients of an increase of infection. Yes, probably is correct. But if you see the data of the alpha studies, you can observe that there is an increase of pulmonary aspergillosis, an increase of septic shock in the arms that add the Mylotarg to 3+7. Attention, so to this point. Move on. And we arrive to the Vyxeos, the combination of liposomal daunorubicin plus cytarabine. interesting drugs that we utilize above all in patients with secondary leukemia. In our experience, we confirm that reported in the literature, a longer neutropenia, very long neutropenia. But in spite of this long neutropenia, we can confirm that there is a less mortality rate for infection in these patients. Why? Some hypotheses we can do. Probably the effect very low of this drug on mucosal can induce less aggressive infection. Is an hypothesis that need confirmation on this point. Moving on hypomethylating agents, decitabine and azacitidine that we use, yes, in myelodysplastic syndrome, but also in AML, mainly in patients unfit or not indicated to be treated with 3+7. Yes, these meta-analysis that take in consideration a lot of studies say us that in this kind of approach that seems very, very easy, very comfortable for the patients is not so. Because comparing with the arm of other treatment that is best supportive care, that is a low dose of RC, is also aggressive chemotherapy, showed an higher incidence of infections, grade 3 and 4 in the methylating arm, mainly in the first 2-3 course of the treatment, at the beginning of the treatment. And when we add this kind of drug to venetoclax, what happened? Look at the last line, venetoclax plus AZA plus POSA, 33% of lung infection. So there is the possibility to have a high number of pneumonia in this kind of patients. Take note. But it is a problem only of acute myeloid leukemia or also of acute lymphoblastic leukemia. Also for these patients, as you listen in these days, there is new drugs, new approach, AML-like treatment, pediatric-like treatment also in the adults. Okay, and what happened? Regarding blinatumomab, the European Confederation of Compromised Hosts said that there is no significant difference of incidence in infection if we compare the patients treated with blinatumomab versus patients treated with FLAG. But a recent interesting paper published last years on a small series of patients treated with blinatumomab said us that there is an increase in this experience of pneumonia, probably fungal pneumonia. And the author suggests in their conclusion that probably a more active treatment for this kind of patients could be useful in order to reduce this risk. Regarding inotuzumab, there is no problem. It is a very easy, a comfortable treatment and apparently did not give infectious complication. But we arrived to CAR-T, just a word. On this experience, they published last years on 53 patients with the TILL treated with CAR-T procedure. Look at there, 6% of patients dead for infection. So it is an important point that you always must take in consideration. Prevention is better than cure, of course, easy to say it. And if we take in consideration the antibiotic prophylaxis, there is a lot of factors that are favorable to this procedure. Because we can reduce the risk of febrile neutropenia, we can reduce the viral reactivation, we can reduce the microbiologic contamination. But there is a problem, antimicrobial resistance, antibiotic resistance. At present, we have a lot of problem with quinolones and Escherichia coli resistant, Klebsiella pneumonia resistance. What we must do? This is a very important point. The ACIL, European Conference on Infection and Leukemia, said us that the quinolone could be useful, yes, but no advantage because the mortality is not changed. It would impact only on bloodstream infection, but there is the risk of increase of resistance. On the contrary, ASCO said us that at present is yet useful to administer to the patients that have expected neutropenia of more than 7 days to utilize this kind of procedure. And regarding the fungal infection, in this study that we performed some years ago, we demonstrated that AML, mainly those that go to the first induction, that have a neutropenia at baseline, that have a low possibility of arrive at CR, a secondary leukemia, all the patients are those patients that must be considered at high risk for a fungal infection. In this kind of patients, all the international guidelines, European and American, agree that posaconazole is the best choice, A1, strong recommendation, wonderful. But what is the problem? The problem is that I said you before, the drug-drug interaction that involved both drugs for AML and drugs for ALL. So the use could be advantageous because it can cause damage to cardiac damage, toxicity due to hyperconcentration of the drugs. What we can do in order to reduce this risk? We can change. Liposomal amphotericin B that was administered at higher dosage in patients with ALL failed to demonstrate a very real efficacy. Some authors from China suggested also in ALL the use of azoles, but it cause an increase of alkaloid neurotoxicity, so maybe is not the best choice. Micafungin, wonderful, have the same efficacy of posaconazole in this study in prophylaxis in AML, but is an endovenous prophylaxis. I don't think that is the best choice, this one. So, remain just two drugs. Rezafungin, an echinocandin of the last generation administered one time a week, so a long-lasting release that can induce a long protection, not only against mold and yeast, but look at there. Rezafungin is able also to have an efficacy against pneumocystis. So we have good drugs that could be useful both for transplant, but also for acute lymphoblastic leukemia and the lymphoproliferative disorders. And another alternative is itraconazole dry powder. There is a trial that will start in Italy, in Europe in the last months that maybe could be useful because, of course, is a drug that not was administered in systemic matter, and so there is the interaction that we could have with the azoles in these cases. So I finish in time. My conclusion, yes, we have new drugs, new opportunities for our patients, wonderful, but we must take note that we must have a great attention to the drug-drug interaction, because in the last years we have a marked reduction of infection and that for this complication in our patients. We must maintain this optimal status. Thank you. Run.
Thank you very much. We have time for maybe one short question. Maybe I can ask, so what do you recommend as prophylaxis for, let's say, pediatric-inspired regimens for ALL patients age less than 40?
Pediatric patients?
Well, age less than 40, pediatric and adult.
At present, I remain of the idea that posaconazole, for fungal infection, I remain of the idea that posaconazole is the best choice, also in pediatric patients. I mean, for antibacterial prophylaxis, in my opinion, nothing. No prophylaxis, because there is, at present, in Italy, in Europe in general, we have a big problem of the resistance, and I prefer not to use prophylaxis with quinolones, also because there is an advantage in mortality. I prefer have good drugs for treat these patients if the infection arrives, but not to administer chemotherapeutic agents them.
Thank you very much. So our last speaker of the session is Dr. Zini, who will talk about morphology in acute leukemias and heme malignancies.
I wish to thank for this kind invitation, and due to the time, I wish just to give you some take-home message why we, in this NGS era, we still speak of the morphology. Morphology is more effective today than in the past. It's included in the rules of the WHO in all the edition. So it's something that should be applied because it is considered a diagnostic tool together other techniques. And what did WHO has been included in this blue book, the rules that people from the ICSH, that is the International Committee for Standardization in Hematology, a NOD committee, has already included for lab people. And this was very important because these rules have been now shared and diffused to clinicians. So we have rules on the blast percentage, we have rules on what are the criteria for defining dysplasia. We have rules how many cells we have to enumerate on peripheral blood and bone marrow at diagnosis. We have rules which kind of cell should be included in the blast count. So if we follow the rules, I think that this diagnostic tool is harmonized. And if you go through the WHO rules, are well identified which cell should be considered blast. And so we have criteria to identify granular blast, to identify megaroblast, and monoblast. And WHO introduced this subtype of blast equivalent cells, that means those cells that should be included into the blast count in well-defined context. And these are the promonocytes, the abdominal promyelocytes, and the proerythroblast in a well-defined context. Moreover, also qualitative recommendation by the WHO, and that are which kind of morphology of the cells, so abnormalities in morphology of the cells, should be considered as dysplastic ones to define, to reach the 10% of dysplasia cell for each lineage in the context of the MDS, 50% in the context of AML with dysplasia correlated changes. And so are absolutely listed in a very, very clear way which are the features to define this erythropoiesis. As you see, I work with the Morphology International Group, and we provide some indication that are included in the revision of WHO. This is the last on this erythropoiesis. Rules to define what is these granulopoietic cells, and rules to define what you have to consider dysplastic megakaryocyte with very well-defined attention on what is a macromegakaryocyte. Because if people does know this, due to the size that is more or less like that of the one myeloblast, you miss megakaryocyte, so you fail your bone marrow report. Obviously, all these changes should be applied in the right context, so should be excluded all those dysplastic changes, not clonal. And again, morphology still represents the first diagnostic screenings in the majority of hematologic neoplasm. And morphology, when well used, can predict molecular genetics abnormalities in myeloid context, as well also in lymphoid malignancies. And remember that the patient cannot choose the morphologists because they go to the lab. But they can choose the clinicians because they go to the net after diagnosis. So a good morphologist still represents a very speedy way to send the patients in a fast diagnostics and prognostication setting. I went very fast to the short time, or skipping the description of morphology, but obviously I will be available for all questions out of this podium. I just spend 2 minutes for people that are interested in morphology, because morphology nowadays, due to ICT, can be practiced at home by remote. So if you are interested in morphology, nowadays we have the HICA campus on morphology, so please follow. It starts from January of this year, and it's a good training for people who wish to go in morphology. Within the Leukemia Net, together to Marie-Christine Benet, I chair the WUP10, the diagnostic group, and every year, in the last 3 months of the year, I launch the Leukemia Net World Cup. It's now starting. If you are interested, mail to Gina Zini and my email address, and you will obviously are freely available. And finally, on the next month in Rome, we have our National Congress, and there is an interactive session on morphology. Thank you for listening.
I have a quick question. As you know, in terms of core binding factor leukemias, we are breaking the rule now. We don't have to have 20% blast to diagnose acute myeloid leukemia. Do you think this list could expand in the future, and other entities could be considered AML because of presence of a cytogenetic or molecular abnormality?
Already there are some acute leukemias that do not need to reach the 20% of blast because there is the marker, the cytogenetic marker.
Yes.
But there are also some leukemia, such as the chronic myelomonocytic leukemia, and there is a big trend to increase the threshold of blast number, and at 30% as in the FAB era. So as all the diagnostic tools, they change according to the experience, the group, and the published data. So the point is to follow also this tool until it is included. When WHO will not include morphology, it's okay. We will work with morphology with less developed countries that do not have other things. But this nowadays it's included, so we have to use. It's okay.
If there are no more questions.
Just a suggestion. Thanks a lot for
Speedy.
you for speed, but particularly also for the suggestion that you are giving in our academy Italian hematologist to be practical. Why you are not promoting a network, an Italian network, collecting all the data, all the imaging? Now we get in most of our institution, we get the possibility to capture the imaging of this kind, but also from some confocal imaging.
Yes.
And why not to make a network which can be shared together?
The network, as for instance, I am in the net lab for the MDS morphology.
Yeah.
I am the Leukemia Net. There is it could not be individual. For instance, I use the scan. When I do exercise, I don't use the single image JPEG. I use the scan of the smear, because morphology is diagnostic when you can check the context, the company cell they keep, because single cell alone is very rarely may be diagnostic. So I'm really open because I spent all my life with morphology. So
Thanks.
this could
Thanks
be.
a lot. We have a very short break of 5 minutes. You can take a coffee and coming back eventually. So we try to rescue our bit delay that we introduced at the beginning of the section. Thanks for moderation.